cerebrovascular accident with complications of alcohol use disorder. The objectives of this presentation are the explanation and discussion of cerebrovascular accident, otherwise known as a CVA, explanation and discussion of alcohol use disorder, we're going to call that an AUD, and a simulated case study. The medical explanation of a CVA, otherwise known as brain attack or stroke. According to the Centers for Disease Control and Prevention, otherwise known as the CDC, a CVA occurs when something blocks the blood supply to part of the brain, or when a blood vessel in the brain ruptures. When either of these situations occur, the brain is damaged, or part of the brain dies. This may cause permanent damage, disability, or death. When we look at this picture here, you notice straight on the frontal cut section of the brain, that bruising area. That bruising area is tissue death. And if you notice that little white box, that's indicating the vein there happened from a blood clot. So the blood clot formed in that vein, and then the vein blocked and caused tissue death to that portion. That form of a stroke or a CVA is called ischemic. There are two types of strokes, ischemic and hemorrhagic. So we're going to first discuss the ischemic. If you look here at the picture, you can see plaque building up in a vein. That is causing blockage or stopping the blood flow to the brain. So an ischemic stroke, or an IS, is caused by the blockage of a blood vessel sending blood to the brain, and it accounts for 87% of all strokes in the United States. The CDC states that a transient ischemic attack, ITA, well, that's a warning sign. That's a mini stroke that we need to be taken seriously, people, because during an ITA, the blood to the brain is blocked, but it's only blocked for a short period of time, no more than 5 minutes. When a patient has an ITA, it's a warning sign of things to come. 911 should be called immediately because we don't know if the person's suffering an ITA or an IS. So the CDC states that more than 1/3 of the people who suffer an ITA, they don't receive treatment, and they will suffer a major stroke within 1 year. So according to the American Heart Association, an IS may also be cryptogenic. What's cryptogenic? Well, it's a big word that simply means unknown cause. The American Heart Association estimates that 1 in 3 IS are cryptogenic strokes, and that it may be caused by an irregular heartbeat, a heart structural problem, hardening of the arteries, or a blood clot disorder. So now that we've talked about the ischemic strokes, let's talk about hemorrhagic. There are two forms, the intracranial hemorrhage, ICH, and the subarachnoid hemorrhage, SAH. So according to CDC, a hemorrhagic stroke occurs when a blood vessel bursts, it ruptures. So if you look at this next picture, you'll see that there's blood squirting out of that vein there. Well, that blood that squirts out of the brain, it has to go somewhere. So where does it go when it leaves the vein? It pulls up within the brain tissue, and it's going to damage that surrounding tissue. So an ICH, remember the intracranial hemorrhage, that accounts for 10% of all strokes. And the ASH, the subarachnoid, those account for 3%. The ICH, those are the most common, and they occur when the artery in the brain bursts. So remember that. It floods the surrounding tissue of the brain. Risk factors of the CVA include advanced age, hypertension, smoking, obesity, diabetes, physical inactivity, diets high in processed foods, saturated in trans fats, diets low in fruits, vegetables, lean meats, and fish. Folks, we've heard this a lot, right? Women with a body mass index greater than 25 kilograms or a weight increase of greater than 11 kilograms in 16 years, and men with a waist to hip ratio greater than 0.92 inches are also at higher risk for a CVA. With and Reinhardt state that high blood pressure is a significant risk factor for IS and intracranial hemorrhaging. Signs and symptoms. According to the CDC in 2019, there are 5 most common signs and symptoms. So let's count those down, folks. Let's start with number 1. Number 1, numbness or weakness. Number 2, sudden confusion, difficulty speaking or being understood. Number 3, difficulty seeing. Number 4, trouble walking, dizziness, or loss of balance. And finally, folks, number 5, sudden severe headache with no known cause. So let's take a peek now at the CDC's video, FAST. Fast is how the video is going to go, quick and fast, but that's not what it's all about. So let's listen up before we miss it.
If you think someone is having a stroke, remember the word FAST. F is for face. Ask the person to smile and check whether one side of their face is drooping. A is for arms. Have the person raise both arms and see if one arm drifts downwards. S is for speech. Ask the person to repeat a short phrase and notice if their words sound slurred. And finally, T is for time. If you spot any of these signs, call 911 right away to get the person to a hospital fast.
Alrighty, folks, fast, remember that. Recovery and damage from a CVA. So recovery may take weeks or years, and many people, they're going to have long-term disabilities. According to the CDC, patients may expect paralysis or weakness to one or both sides of their body. They're going to have trouble thinking with alertness, attention, learning, judgment, memory difficulty. They're going to have trouble with speech or understanding, difficulty controlling or expressing emotions, numbness or strange sensations, pain in their hands and feet that worsen with movement and change in temperature. They're going to have difficulty chewing or swallowing, problems with their bladder or bowel control, and depression. CVA rehabilitation is a vital part of these patients' recovery. Patients are going to need to work with speech, physical, and/or occupational therapists to recover. And according to the CDC, a speech therapist is going to help these people with problems such as producing or understanding speech. A physical therapist, they're going to use exercises to help these patients relearn movement and coordination for things such as walking. And an occupational therapist, well, they're going to aid folks with those things that we love to call the activities of daily living, such things as self-feeding, dressing, bathing, reading, and writing. Medical treatment of a CVA. Let's first take a peek at the lab values of interest, according to With and Reinhardt. There's primary and secondary to CVA. So let's first take a peek at primary. We're going to look at increased glucose, 2-hour postpartum glucose, and glucose tolerance. There's going to be an increase in retinol binding protein, increased blood pressure, and increased cholesterol. Secondary to CVA is going to be an increased blood urea nitrogen. We like to call that the BUN. Increased white blood count and increased red blood cell count. There's going to be a decreased prothrombin time. Sorry guys, I have a hard time with that one. And a decreased hematocrit and hemoglobin. Stages of treatment. There are 3 stages: prevention, acute care, and post. Stage 1, preventative care. That's our outpatient and home-based. Patients in the medical team, they're going to focus on healthy lifestyle of diet and physical movement in conjunction with medication. Preventative treatments, those treat the underlying risk factors, things like hypertension, heart disease, and type 2 diabetes. Prevention of a secondary CVA, that's going to include continuing lifestyle modifications of diet, physical movement, stress reduction, and medication. Patients are commonly going to be placed on antithrombotic medications. This class of medications Those include antiplatelet and anticoagulant drugs, but we're going to talk about those in a little bit. Stage 2, that's acute care. That occurs in the hospital. Acute care tries to stop a CVA while it's occurring or immediately after. This form of care involves quickly dissolving or removing a blood clot in cases of an ischemic stroke, or it's going to stop the bleeding in or around the brain if it's a hemorrhagic stroke. Certain medications are going to aid or stop a CVA, and those medications must be administered within the first 3.5 hours of a CVA. Folks, vitally important to call 911 right away. And then stage 3, post-care. This is also referred to as rehab or the rehabilitation stage. Post-care, this helps patients transition from hospital to home again. Often patients, they're going to be discharged from the hospital to a rehab center for a period of therapy. Some commonly prescribed medications are 4 classifications: preventative, clot dissolving, antihypertensives, and cholesterol lowering. An example of preventative is warfarin. That just kind of thins out the blood a little bit and helps it to keep moving around. Clot dissolving, well, aspirin is the most prescribed. It's cheap, but it's effective. Antihypertensives, those are ACE inhibitors, angiotensin receptive antagonists, beta blockers, calcium channel blockers, and our diuretics. Excuse me. Cholesterol lowering medications, those are going to be cholesterol absorption inhibitors, niacin, and statins. MNT, medical nutritional therapy, that's what I'm here for, guys. That is what I love doing. So let's talk about that. Prevention begins with lifestyle modifications, and it continues through behavioral and dietary changes. These changes are key to CVA prevention. So the Florida Academy of Nutrition and Dietetics Manual of Medical Nutritional Therapy, that's a long one, recommends the following modifications. They recommend reducing the intake of saturated fats to less than 7%, the removal of trans fats from the diet, and limiting alcohol consumption to once a day for women and 2 drinks a day for men. They recommend an increase in fiber, fruits, vegetables, lean meats, and fish. They continue to reduce sodium intake to less than 2,400 milligrams a day. They recommend increasing physical movement to a minimum of 150 minutes a week and a reduction in body weight by 5%. Folks, just 5% is going to reduce the risk of heart disease and blocked arteries. And this is nothing new. We have all heard these recommendations before. Acute care MNT. Our primary goal with acute care is to restore nutrition, reduce the risk of dehydration and malnutrition. Secondary for acute care is going to be education and counseling. Post-care. For many of our patients, this is a time when they get to develop a new relationship with food. They get to start looking at food in a new way and understanding nutrition and physical movement a little better than maybe they did before. Classes in shopping, nutrition, healthy cooking, and physical movement, these classes are all going to aid our patients to a fuller and a healthier recovery. Cost of medical care is approximately 80% of all strokes in the United States are preventable, guys. It's estimated that $34 billion annually is spent on disability-related costs that are due to strokes. Guys, that's kind of astronomical when you think about it. 80% of all strokes are preventable. Percentage of CVA by classifications. Ischemic. Ischemic is when we blocked our arteries, we blocked our veins, so that's 87%. And then we're looking at our hemorrhagic strokes. Intracranial makes up 10%, and the subarachnoid is only 3%. So guys, we can make a huge difference if we just do some lifestyle modifications here and aid our patients with a better understanding of lifestyle changes. Current statistics on CVAs, the American Heart Association states that 795,000 people annually suffer from a CVA. High-risk segments of the population include our older Americans, African Americans, and individuals of lower socioeconomic status, and then our people living in the southeastern region of the United States. According to the CDC Stroke Facts of January 31st, 2020, someone in the United States suffers a stroke every 40 seconds. Every 4 minutes, someone dies from a stroke, and the leading cause of long-term disabilities in the United States are strokes. Strokes are the 5th cause of death in the United States. Alcohol use disorder, AUD, otherwise known as alcohol abuse, alcohol dependence, and alcoholism. The U.S. National Library of Medicine stated in 2017 that alcohol use disorder is a disease that affects approximately 18 million adult Americans. AUD is known by several names, as we've said, alcohol abuse, alcohol dependence, and alcoholism. An AUD may cause negative life-altering changes in the lives of those with the disease and their loved ones. According to the U.S. Library of Medicine, AUD is a disease that causes the strong need to drink, and it disables the person's sense of control. Once a person with an AUD begins to drink, they're unable to stop, and this leads to negative emotional state of anxiety and irritability. The medical explanation of an AUD is that there are many causes. We have genetics, physiological, psychological, and social factors. And according to the American Psychology Association in 2021, psychological traits that may include impulsiveness, low self-esteem, and need for approval. They also state that victims of assault and abuse are at a higher risk of developing AUDs. How does our liver play a role in AUD? Alcohol is absorbed in the bloodstream, and it's processed in the liver. So according to the U.S. National Library of Medicine, the human liver is amazing. It is capable of processing approximately 1 drink of ethanol, that's the main ingredient in alcohol, per hour. 1 drink is defined as 12 ounces of beer, that's 1 can, folks, 5 ounces of wine, or 1.5 ounces of whiskey. When greater amounts of ethanol are consumed than the liver is capable of processing, the effect may be impaired judgment or other behavioral changes. According to the U.S. National Library of Medicine, these changes are referred to as intoxications. The level of intoxication is going to vary from person to person. It's based on age, gender, body weight, and if that person is eaten while consuming alcohol. AUD increases the risk for additional diseases, such as cancers, alcohol fatty liver disease, which may lead to end-stage liver disease, hepatic encephalopathy, malnutrition, esophageal varices, ascites, edema, fat malabsorption, portal hypertension, and insulin resistance. Signs, symptoms, and diagnosis of AUD. The American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorders, 5th edition, states 2 or more symptoms must be present for the diagnosis of AUD. According to the 2021 article in NIH, Rethinking Drinking Alcohol and Your Health, these are the signs and symptoms that a person should look for if they're concerned they may have AUD. You have times when you ended up drinking more or longer than you intended. You have more than once wanted to cut down or stop drinking or tried to, but were unable to. You spend a lot of time drinking or being sick from drinking or getting over drinking or the after effects. You want to drink so badly that you couldn't think of anything else. You found that drinking or being sick from drinking often interfered with taking care of home, family, or caused job troubles or school problems. You continued to drink even though it caused trouble with family members and friends. You have given up or cut back on activities that were important or interesting to you. Or that gave you pleasure in order to drink. You have more than once gotten into situations while or after drinking that increased your chance of getting hurt, such as driving while impaired, swimming, using machinery, walking into dangerous areas, engaged in unsafe sexual practices. You continued to drink even though it was making you feel depressed or anxious, or it added to other health problems, or after having had alcohol-related memory blackouts. You had to drink much more than you once did to get the same effect that you want. You found that your usual number of drinks had a much less effect than before. Or finally, you found that when the effects of alcohol wear off, that you have withdrawal symptoms such as trouble sleeping, shakiness, restlessness, nausea, sweating, a racing heartbeat, anxiety, or seizures. If you can answer yes to 2 or more symptoms, please seek help. Medical treatment for AUD. Let's look at the lab values because according to Whiff and Reinhardt, there are primary lab values related to alcoholism and secondary that are related to liver disease and/or cirrhosis. So the primary related to alcoholism is an increase in osmolality, decreased level of folic acid, decreased level of magnesium, decreased level of phosphate, increased blood alcohol test. That test measures the alcohol in a person's blood. Secondary related to liver disease and/or cirrhosis. These are increased glucose tolerances. That's related to your liver disease. Increased prothrombin time is also liver disease. Increased levels of transferrin saturation, liver disease. Increased level of B12 is severe liver dysfunction. Decreased levels of albumin could indicate cirrhosis. Decreased levels of BUN, liver failure. Decreased level of cholesterol could indicate liver disease. Decreased levels of creatinine, severe liver disease. Decreased levels of glucose, liver disease. Decreased levels of hematocrit and hemoglobin could indicate cirrhosis. Decreased levels of prealbumin, liver disease. Decreased levels of red blood cells could indicate cirrhosis. Decreased levels of total iron binding capacity, cirrhosis, and decreased level of transferrin, again, indicator of possible cirrhosis. Medical treatment. Currently, there is no cure for AUD. Abstinence and treatment from a trained psychologist specializing in substance abuse therapy are the most beneficial forms of treatment, according to the American Psychological Association of 2021. Psychologists will help a person to assess the traits and degree of problems that this individual is experiencing, and it's going to help them to move through the stages of change so that they can resolve these psychological issues that are involved in the AUD. The National Institute of Alcohol Abuse and Alcoholism, NIAAA, reports that people with an AUD are more likely to seek help from their primary care physician than treatment from a trained psychologist. They further stated that only 4% of individuals seeking treatment are actually placed on medications that are going to help them with abstinence. Many individuals find that support groups such as Alcohol Anonymous are beneficial. AA was founded by Bill Wilson and his doctor, Bob Smith, in 1935. Dr. Smith wrote and published Alcoholics Anonymous in 1939, and this book is the foundation of the program's 12-step approach to recovery. AA chapters may be found globally and are community-based programs, and in addition, AA meetings provide support and opportunities for people with AUD to share experiences, struggles, and to find support from others who struggle with AUDs. There are 3 categories of medication for AUD. Deterrent agents, which are medications that help patients with AUD to not want to drink. Prevention of cravings. These are medications that reduce the physical craving of alcohol. And then withdrawal aids, medications that help the patient with symptoms of alcohol withdrawals. Medical nutritional therapy. Woohoo! Florida Academy of Nutrition and Dietetics, FAND, state that diets high in alcohol and low in nutritional dense foods are going to leave a person at risk for megablastic anemia dehydration, protein malnutrition, energy malnutrition, lipid dysregulation, electrolyte imbalance, vomiting, diarrhea, and fat malabsorption. Alcohol reduces the intestine's ability to absorb B6, thiamine, folic acid, pyridoxine, vitamins A, E, C, K, and D, zinc, magnesium, iron, calcium, selenium, and potassium. FAND recommends that 200 milligrams of thiamine supplements are given daily, and additionally, magnesium may also be necessary as folic acid supplements as well. FAND encourages a balanced diet and the elimination of alcohol for recovery and good health. FAND further notes that dehydration is often common in patients recovering from AUD. They stress the importance of hydration, drinking adequate fluids between and during meals. In addition, FAND recommends that a healthy lifestyle includes plenty of physical movement, reducing or quitting smoking, plenty of rest, stress reduction, and continued counseling or participating in a local support group, such as AA. The current statistics on alcoholism are sobering. According to the National Institute on Alcohol Abuse and Alcoholism, in 2019, 14.5 million people ages 12 years and older suffer from AUD. Additionally, it's estimated that of that 14.5 million people, 424,000 are adolescents between the ages of 12 and 17. Again, that's 424,000 adolescents between the ages of 12 and 17. The NIAAA state that there's a new trend in drinking, and this trend is called high-intensity drinking. High-intensity drinking, it's defined as consuming alcohol at levels that are 2 times the gender-specific binge drinking threshold. The NIAAA continue to report that those who consumed alcohol at 3 times the gender-specific binge drinking threshold were 93 times more likely to have an alcohol-related emergency department visit. They reported that the trend of binge drinking in 2019 was 25.8% of the population 18 years or older. They further stated that of this population, that they reported to have engaged in binge drinking within the last month, and that 6.3% of that population reported to have engaged in heavy alcohol use within the past month. AUD and associated death rates in the United States. The CDC states that alcohol is responsible for more than 95,000 deaths annually within the United States. They continue to state that these deaths shorten the lives of those who died on average almost 29 years. So when we think about that, subtract 29 years from your life. Whomever's listening to this, just think of your current age and subtract 29 years. That's a total of 2.8 million years of potential life that's lost. Alcohol-related deaths are the #1 preventable death in the United States. It's been estimated that in 2010, the national cost associated with alcohol-related deaths was approximately $250 billion. Those are sobering statistics. So now let's take a look at our simulated enteral nutrition case study. An 84-year-old male who was admitted with a diagnosis of CVA. Let's take a look at our assessment portion first. I'd like to introduce you to Mr. Marcus Lewis, an 84-year-old male that was admitted with a diagnosis of CVA. His family reports that he has a long history of alcoholism. Mr. Lewis suffered a right CVA that has left him with this difficulty communicating and swallowing. Mr. Lewis's family reported that they had noticed that he's been losing weight since their last family gathering at Christmas, and that they noticed he has begun to limit his intake of food to black coffee, beer, and fried eggs. The patient's family remarked that he has reduced his usual intake by more than 75% within the past 2 months. Mr. Lewis's past medical history indicates a long history of alcoholism, the right side CVA with lasting effects of the inability to communicate and marked difficulty swallowing. His diet history was revealed by his family that he's currently consuming coffee, beer, and fried eggs. They shared that his usual diet included meals with the family, frozen dinners, eggs, bacon, limited fruits and vegetables. Mr. Lewis's current and history intake confirm that he has a poor quality of nutritional intake, low in high quality protein, vitamins and minerals, and fluids, and it's high in fat, sodium, and alcohol. These suggest further dietary insufficiencies. Mr. Lewis's nutrition-focused physical exam was extensive. I will touch briefly on the highlights here. While looking at Mr. Lewis's face and mouth, I noticed that his gums and tongue were swollen and bleeding. I asked him if he wore dentures, and Mr. Lewis shook his head yes. I asked Mr. Lewis if he had been wearing his dentures in the past 2 to 3 months, and he shook his head no. I asked if his dentures were hurting him, and he shook his head yes. I continued the nutrition-focused physical exam, and I've noticed that his skin is very thin, very dry, has abrasions on it. His overall appearance is that of weakness and wasting. Cachexia is definitely obvious. He is pale, lacking color. I have noticed that he has many signs of malnutrition. On his back, I noticed on the lower spine a stage 2 pressure ulcer. I also noticed on his tailbone a stage 2 pressure ulcer. While continuing to look over Mr. Lewis, I continue to see signs of malnutrition, bone protrusion. His iliac is definitely very visible. I've noticed that just a gaunt look, his conjunctiva. Overall, there are signs there of malnutrition and dehydration. His anthropometrics are his height is 5'8", current body weight is 153 pounds, usual body weight is 180 pounds, so that means he has a percentage of usual body weight at 85% currently. The ideal body weight, give or take 10%, is 160 pounds. His ideal body weight percentage currently is 95.62%, with a BMI of 21.95. So we can see that Mr. Lewis is within a good weight. However, he has lost significant weight for himself. So now let's take a peek at his lab values in relation to his medical condition. We see that Mr. Lewis has an elevated bun, and this is a possible indicator of dehydration, but also of renal failure. We have elevated creatinine, which indicates impaired renal function. As elevated sodium indicates a possible increased intake through diet or IV, but I'm not really seeing that, and that he has a decreased loss of excessive body water loss through sweating or diabetes and insipidus, and I'm not seeing that. But his osmotic diuresis, which is increased urination caused by the presence of substance in the small tubes of the kidney, that takes me back to renal. He has elevated potassium, which indicates a possible renal failure or, again, dehydration. He has decreased albumin, which indicates possible malnutrition. Acute and chronic inflammation and infection, so that's going to be from the stage 2 pressure ulcers or the gums from ill-fitting dentures. It could also be from alcoholism, and again, renal disease pops up. So let's just take Mr. Lewis's lab values and put them on the back burner for right now. Medications are not currently listed in his chart, so I'm going to need to talk with the attending physician about those. Mr. Lewis's estimated needs were calculated using Aspen guidelines for critical care, and the calories come in at 2,100 to 2,450 daily. His protein is 91.5 to 110 grams daily. Fluids were estimated using 30 milliliters divided by actual body weight. That comes in at 2,100 milliliters daily. And the fiber is 10 to 20 grams of fermentable soluble fiber given in divided doses over 24 hours. Diagnosis. PES Statement 1. Severe malnutrition in the context of chronic illness with stage 2 pressure ulcers and inadequate fluid intake, related to inadequate protein energy intake with increased protein energy needs in a setting of stage 2 pressure ulcers, swallowing difficulty caused from damage of right side CVA, as evidenced by Aspen guidelines of significant unintentional weight loss of 15% and greater than 6 months in the absence of edema with inadequate energy intake, less than or equal to 75% of estimated energy requirements for greater than 1 month, the Braden Scale score and nutrition-focused physical exam. PES statement number 2 for Mr. Lewis is poor nutrition quality of life related to difficulty swallowing, history of alcoholism, the inability to communicate needs verbally as evidenced by weight loss of 27 pounds in 6 months, the inability to speak, and family statement of nutritional intake. Mr. Lewis's current nutritional prescription ordered by his physician was written for Isocal HCN through a nasogastric tube with an initial rate of 50 milliliters an hour, advanced as tolerated to a final goal rate of 100 milliliters per hour. However, due to abdominal distension and excessive residuals, the order for Isocal HN was ordered at 65 milliliters per hour. This new enteral prescription provides 1,872 calories, 84.24 grams of protein, 1,260 milliliters of free water. As we can see, this prescription does not meet Mr. Lewis's daily requirements. So it's my recommendation that Peptamen 1.5 be administered at a rate of 62.5 milliliters per hour. This lower rate is going to be better tolerated and will meet Mr. Lewis's nutritional needs as follows. It's going to provide 2,250 calories, 145 grams of protein, 1,158 milliliters of free fluid that will be supplemented with 235.5 milliliter flushes 4 times daily, and 6.5 grams of fiber. I'm going to additionally recommend adding 3 ounces of prune juice 4 times a day to his tube feedings to meet his daily fiber requirements. The MNT treatment plan, as you can see, is going to be handled through a multi-step process. The first step is I'm going to stabilize his nutrition and reestablish hydration. I'm going to do this by changing his formula to the Peptamen 1.5 and adding the additional flushes. His nutrition and hydration needs are going to be met at a lower rate with less formula. I'm also going to request that his bed be elevated 45 degrees to prevent aspiration. I'm going to order chlorhexidine mouthwash swabs twice daily for oral hygiene. And then I'm going to discuss with the attending physician the gum and mouth sores that I discovered during the nutrition-focused physical exam, because I'm concerned they may be infected from his ill-fitting dentures and malnutrition. The next step is I'm going to discuss with his attending physician the placement of a JPEG with a continuous feed for long-term nutritional needs. This method of nutritional delivery will reduce that risk of aspiration pneumonia, his gastric residuals, malnutrition, and future dehydration. The third step in care is going to be to discuss with Mr. Lewis and his advocate the placement of the JPEG. Mr. Lewis is able to hear and he does communicate nonverbally, so it's important that I include him on this conversation, and he needs to understand the importance of a JPEG placement, and his advocate needs to be a part of that conversation as well. I will also contact the long-term care facility that Mr. Lewis will be transferred to for rehabilitation to discuss with that dietitian the treatment plan that Mr. Lewis has received while here at Erlanger South. I'm then going to educate Mr. Lewis and his advocate on the importance of the JPEG placement and also good oral care. I'm going to use a JPEG model and demonstrate the procedure for complete understanding. I'm going to stress that the continuing use of the chlorhexidine mouthwash swabs twice daily once he leaves Erlanger South will be important. And then I'm going to ask them if they have any questions. Mr. Lewis's labs, remember I said we're going to put those on the back burner. Well, now we're going to pull this back out and look at them because they are part of this acquisition of additional information that I'm curious about. When we looked at his labs, just about all of them had an indicator for renal function. That could be an underlying cause of these lab values. So I want to discuss with his attending physician my concerns. While it's out of my scope of practice to ask that his renal be looked at, I do want to be that second pair of eyes for the physician. So I'm going to ask that we look at Mr. Lewis's GFR, calcium, phosphorus, and chloride labs. And then I'm going to be keeping an eye on Mr. Lewis's daily chart for his daily ins and outs. And then I also want to mention to the attending physician that I requested his blood pressure be taken during the nutrition-focused physical exam because it hadn't been charted yet. And when the nurse took it at that point, it was high. So that could be a possible explanation for a deeper renal problem. Pardon me. Renal function may be affected by multiple factors, and without a complete chart for Mr. Lewis that includes his medications and a full past medical history, I'm not sure what the underlying cause is, but I do feel that his labs and current blood pressure are telling me to explore further. His blood and potassium levels also indicate that it could just be dehydration. Decreased albumin is also related to several factors, such as it could be his pressure ulcers, history of alcoholism, or malnutrition. Mr. Lewis remains on continual tube feeding, so dehydration and malnutrition issues should resolve themselves. Would an oral diet be given at any point? Well, that's out of the scope of the dietitian, but I will state that Mr. Lewis suffered the right side CVA that affected his speech and his ability to swallow. So his right side CVA left him with sensory and cognitive defects that are causing muscle weaknesses of tongue and lips, making chewing, swallowing, and tasting problematic, and they do increase his risk of aspiration. Mr. Lewis's ability to verbally communicate and living alone did leave him without care, and he suffered stage 2 pressure ulcers, malnutrition, dehydration, and oral care as a result of that. It is my concern that if placed back on an oral diet, he's going to run the risk of aspiration pneumonia, additional dehydration, malnutrition, and pressure ulcers, which will bring Mr. Lewis back into our care here at Erlanger South. As I stated in my treatment plan, I would discuss with the attending physician the placement of a genooscopy for a continuous feeding. I further recommend that the hospital social worker discuss with Mr. Lewis and his advocate that arrangements be made for Mr. Lewis regarding daily assistance with his JPEG care. My plans to evaluate the outcomes of interventions and my plans for follow-up, well, the Peptamen 1.5 and placement of the JPEG should prevent further abdominal distension and excessive residuals while allowing Mr. Lewis to meet nutritional and hydration goals. But I will be monitoring his weight gain daily and assess for wound healing to ensure adequate protein. Additionally, I'm going to monitor his labs for improvement values. I will request to see prealbumin and nitrogen balance labs as markers of nutritional adequacy. And I'm going to request that these labs be taken now and again in 3 months for continued nutritional assessment. These labs are glucose, BUN, creatinine, his electrolytes, his calcium, phosphorus, liver function tests for sure, triglycerides, urine, and then his C-reactive proteins. And then finally, I'm going to reach out to that long-term care facility. I want to discuss with the dietitian Mr. Lewis's case because I want to ensure that he has a smooth transition from here at Erlanger South to their facility. The case study summary is that Mr. Lewis does have a history of CVA. In addition, he has a history of AUD, and together that can muddle the waters of exactly what's happening here with his lab work. And then there is still further information that we need to gather for him. So I'm going to be documenting all of my findings from the nutrition-focused physical exam, my PES statements, my treatment plan, my discussions with his attending physician, the social worker, the long-term care facility dietitian, and also my education sessions with Mr. Lewis and his advocate. In summary, Mr. Lewis has a history of alcoholism. However, I don't believe that to be the direct cause of this hospitalization. I do believe that there is a potential renal issue that's underlying and that could be a cause of his current lab values. His blood pressure is high, which is a warning sign of a deeper issue. His ill-fitting dentures have caused mouth pain and have prevented him from wearing them. The timeline with the mouth pain coincides with his weight loss, and there also may explain why his diet changed dramatically. The right side CVA has left him unable to communicate verbally, and therefore he was unable to call for help when needed. His pressure ulcers were due to a loss of muscle strength and malnutrition. Altogether, this was a cascade of events that led Mr. Lewis here to Erlanger South. In summary, today the objectives have been met. I gave a thorough explanation and discussion of CVA, both ischemic and hemorrhagic. I discussed exhaustively AUD, which is the leading cause of preventable deaths in the United States. And then we discussed Mr. Lewis, our simulated case study, and noticed that AUD complicates and increases risk factors for other diseases. My references are stated here. And at this time, I'm happy to take any questions and answers that you may have.